Good morning, everyone. We're going to get started. So this is a new format for us. Let's keep this very interactive today. We're doing a community grand rounds. We have two phenomenal panelists with us here, Doctors Daniel Raper and Luis Savastano, both of whom you know recently joined our faculty within the last 6 months. We're extremely lucky, fortunate to have them. Dr. Raper was a fellow with us and did his training at the University of Virginia, was a fellow with us 3 years ago now. And Dr. Luis Savastano comes to us where he was from Mayo Clinic, where he was an attending for the last 3 years, did his training at the University of Michigan and his MD PhD to ask questions. So let's have some back and forth on this. So first, Dr. Daniel Raper is going to start with his case presentations. Dan?
Thanks so much, Adib, and thanks so much for giving us the opportunity to present today. I think this is going to be fun. We're going to do it in a case-based format, so let's just dive into the first case here. Let's see. So this is a 28-year-old man with no past medical history. He collapsed while he was at work on a construction site, and he quickly became obtunded. So he came to the emergency room. He wasn't opening his eyes. He did have a cough and gag, his pupils were reactive, and he was extending. So he had a pretty poor neurologic exam. He immediately had an EVD placed and had a CTA, which you can see shows this small medial parietal arteriovenous malformation. And so my first question to everyone is, you have this presentation of this man, he's not doing very well. What is the chance for recovery of functional independence for this patient with a ruptured AVM? And I'll give a few seconds to think of what's your estimate of, you think, the functional independence? All right, Ilana, do we have some results? So almost half people think less than 25% chance. Well, that's interesting. So, of course, the outcome will depend on the presentation, neurologic status, age, and certain AVM factors. And there is a range of stroke scale presentation with ruptured AVM, with an overall mortality related to hemorrhage of about 10% and overall morbidity 20 to 40%. But this varies widely in the literature. And almost 75% of people who present with a ruptured AVM will have some neurologic deficits by the time they leave the hospital. However, almost up to 85% of patients actually can become independent in their ADLs at follow-up. In some series. Of course, this is confounded by intercurrent treatment of AVMs, but in general, ruptured AVM is quite different from, an ICH where we have the ICH score or traumatic presentation with low, low neurologic status. In that, people with brain AVMs who suffer rupture have a pretty good chance of recovering well. And that's something that we need to remember when they first present. There is a score that we have, which is called the RAG score, that's been developed. There are a few others that have been less popular, but we can use scores like this to estimate the outcomes for patients who have ruptured brain AVMs based on a number of factors like the Hunt-Hess score, their age, whether the AVM is eloquent or not, and whether it has deep venous drainage. And these can help us predict, some functional outcomes over time in the long term. So let's return to the case. And the next question, when should this AVM be intervened on? Should this be emergent? Should it be within the first 2 weeks? Maybe in the first couple of months? Or should we just wait and see how the patient recovers? And then if they do well neurologically, then we can think about whether or not it should be treated. Maybe I'll bring the panelists in and see what the other panelists think about this.
Yeah, Dr. Savastano, what would you do? When would you treat this patient?
Yes, I think there are three main issues with this patient. Number one is the intracranial hypertension. So definitely, you have to aggressively manage this with CSF drainage and medical therapy. If despite that, the patient is still having very high ICPs or basically signs of herniation, then you have to take him to the OR emergently. Not ideal, because that is a high risk intervention on a full angry brain, but basically sometimes you're forced to do that. So if you are lucky and the intracranial hypertension can be managed medically and with a ventriculostomy, then you need to think what are the things that you can do to decrease the risk of an early re-rupture. And by that, I mean that sometimes there are feeding aneurysm or intranidal aneurysms that are the etiology of the bleeding. And if you can basically occlude those lesions, mostly with endovascular approaches, you can gain time, 1 or 2 months basically, for the hematoma to resolve. And then you can take the patient a couple of months later for curative treatment of the AVM, which is probably going to be surgical in this case. So that will be my approach.
Let's see what the audience thinks. So interestingly, there is some thought among the audience that they would take this patient emergently. So that's interesting. In fact, I tend to have a very similar strategy and philosophy to Dr. Savastano in this case. The first thing that he mentioned is control of elevated ICP. And actually in this case, after we placed the EVD, the patient did have elevated ICPs. And so I took the patient for a decompressive craniectomy without a treatment of the AVM or clot evacuation. And that treated the ICP, that allowed the patient to be safe and allowed us to plan for the next stage of treatment. When we're thinking about the optimal timing of treatment for ruptured AVMs, we have to think about two things. We have to think about the risk of rehemorrhage and how this changes over time, and then the risk of treatment and then how that changes over time. So for rehemorrhage, the risk of future hemorrhage, we know, is twice as high for ruptured AVMs compared with unruptured AVMs. It's about, up to 8% per year, whereas we in general think about unruptured AVM hemorrhage risk in the range of 2 to 4% per year. But in the first year after rupture, you have the highest risk of re-rupture. So if you think about delaying a treatment for 4 to 6 weeks, you're really not risking very much in terms of rehemorrhage. The risk is less than 1% that you're going to suffer a rehemorrhage in the first 4 to 6 weeks after AVM rupture. However, if it does rebleed, the permanent morbidity is very high. And so this is argues towards treatment.
Can I stop you for
absolutely.
1 second?
Yeah.
We have a question from Dr. Maloney, and I wanted to see both of our panelists, what they think. Dr. Maloney asked, is there any role for initial decompressive hemicraniectomy in the community if the patient is herniating before transfer to another center? What do y'all think? Luis, what do you think?
Yeah, so I think that, a decompressive hemicraniectomy can potentially save the patient's life. And early on, what you really need is to control the intracranial pressures. The risk of a re-rupture is relatively low. And if you can basically secure, or I would say, control the intracranial hypertension with decompression, and then transfer to a center that they can provide curative treatment to the AVM, I think that's a very reasonable approach.
Yeah, I would definitely agree with that. And I think most of the time that's very safe. So I think there is probably a little bit of hesitancy on the part of community to do a decompressive hemicranie in some of these cases. The only case that I'd be really worried about is if the clot extends to the cortex, in which case there is a potential for destabilization, if you get rupture through the cortex, and then you could have to deal with the AVM at the same time. But if you have a deep hemorrhage, if you have a nice rim of cortex, certainly in this case where we saw most of the bleeding was intraventricular, and it's a deep hemorrhage, that would be something that would be very safe to do in the community and transfer for definitive treatment.
Yeah, I would agree with that. Dr. Savastano, did you want to say something?
Yeah, I was going to echo Dr. Raper's comment that by decompressing, basically, especially if you open the dura and if you enter the hematoma, there is a possibility to re-rupture the lesion. So this is basically, the decompression is exclusively for the bone and potentially the dura, but not enter into the hematoma, because that could, you could be forced to deal with the AVM as well if you do that.
Yeah, and Dr. Maloney typed a follow-up. When transferring, sometimes there can be delays in transfer with a tight brain. The city only has one receiving helipad. So what do we think about that? And maybe I'll just answer. I think if a patient is herniating and has a blown pupil, I think the chances of that patient doing well without a decompressive craniectomy in the community is pretty low. Regardless of whether the transfer is very fast or very slow, it's going to take at least an hour or two. So if a patient has already blown a pupil, I don't think they're going to do well if the decompressive craniectomy is not done urgently before transfer. That would be my take on that.
Great. So let's continue with thinking about the timing of treatment and the risks and how that changes over time. So we know in terms of surgical risk that we have, the Spetzler-Martin and the Lawton scales to help us assess the surgical risk. And we know that for low-grade AVMs, that there is a very low risk of major and minor morbidity with surgical treatment. The radiosurgery risk is a whole separate thing, and it doesn't follow the same risk pattern as the Spetzler-Martin scale, but there have been validated scoring systems that have been developed to assess risk with radiosurgery. And with stereotactic radiosurgery, we can get up to 90%, 70 to 90% complete obliteration of AVMs with treatment over time. And we know from some evidence that there's no actual benefit to waiting to start SRS after a bleed. So you can do SRS treatment for ruptured AVMs just as you can for unruptured AVMs. In terms of surgical treatment, there is some risk associated with early surgery in that brain parenchyma could be more friable, hematoma can be less easily treated in the first couple of weeks after rupture. And that's one of the impetus to wait a little bit of time before doing a definitive surgical treatment to make the surgery easier and safer. So overall, to summarize, in my opinion, it's reasonable to treat an AVM after a period of stabilization, anywhere from 2 to 6 weeks after initial hemorrhage. Even 1.5 to 2 weeks is usually okay. We didn't talk about it, but preoperative embolization is a good option to make surgery safer, as long as it doesn't add morbidity to the procedure on its own. So here's the angiogram that I did for this patient, and you can see that this is a very compact, small AVM, primarily fed by a distal branch of PCA, a couple distal branches of PCA, with a primary venous drainage that is superficial up into the superior sagittal sinus. But you can see there is some trace of deep venous drainage into the straight sinus as well, which makes it a Spetzler-Martin grade 2 AVM rather than just a Spetzler-Martin grade 1 AVM. So what treatment would you advise here? What do you guys think?
So I think considering that is a young patient with a ruptured AVM and in a surgical approachable, that would be my preference. Basically surgery, probably without preoperative embolization in this case.
What do we think? There we go.
100%.
100%. Well, just to summarize the literature here very quickly by treatment approach. This is my summary, general percentage summary of what we see in the literature by approach. And looking at the approach, the rate of complete obliteration, and a couple of things, permanent morbidity and your ability to get a good functional outcome at late follow-up. You can see surgery is very good at obliterating the AVM, has a reasonably low morbidity rate for grade 1 and grade 2 AVMs, with a high 80% a good functional outcome at late follow-up. SRS is a little bit less obliteration. Morbidity is probably also a little bit less, and maybe a little bit less ability to receive a functional outcome. Embolization for cure, something that we hear a lot about in the literature and is certainly very popular in Europe, is much worse at getting complete obliteration. And there is quite a high risk of permanent morbidity in the literature, with a mortality rate that's up above 1%. And observation, and we have to talk about Aruba, there is a risk of 10% in Aruba of death or symptomatic stroke for patients who aren't treated. So overall, I think that I agree with the panelists, obviously, and everyone who's voted that surgery is a good option here. We'll go through what I did in just a moment, but I just wanted to mention this other study that is quite interesting because after Aruba, which clearly had a big impact, we've seen a decrease in the annual intervention rate for AVMs, but we've seen an increased incidence of rupture. And so even though, even though Aruba suggested that it could be safer to watch some AVMs than treat them, in fact, we've seen an increased burden of ruptured AVMs in the past 5 to 6 years, correlated with a change in practice around Aruba. And this is something that's quite alarming to us because we think that certainly many AVMs can be treated safely, and it's actually better for the patient to reduce their future risk of morbidity to treat AVMs rather than to just observe many AVMs. I don't know if Adib, Dr. Abla, you have any comments on that too?
Yeah, I think we just need to remember with Aruba, they lumped everything into one group in terms of treatment. So embolization for cure or even for not for cure, radiosurgery and surgery. And I think that was one of the mistakes. They also didn't report the success in curative treatment of the treatment arm in that study, which was a glaring omission. So not only did the patients not only were they put at risk for the procedure-related morbidity, but they also could have gone on to rupture with incomplete treatment.
Mm-hmm. Exactly. And finally, just to finish with the outcomes from this case, I did do a surgical resection of this AVM a couple of weeks after the rupture. I did a preoperative embolization the day before through that distal PCA branch with onyx, which left very little filling of the AVM. And then treated it, and then came back later to do a cranioplasty. The patient had made quite a good recovery, probably still MRS3, but he was at home. He had some radiographic hydrocephalus, you can see, but was actually improving clinically. So we were watching that and not immediately shunting him, but seeing if he needed that over time. So that was the outcome from that case, and I'm happy to answer any questions before we move on to Dr. Savastano.
Yeah, very nice, Dr. Raper. That's a nice outcome. Do we have any questions from the audience? All right, Dr. Savastano, take it away.
Sounds good. Thank you. All right. So I'm going to present a different case now of a 77 years old lady that was on warfarin for AFib that presents with 2 weeks of headaches. And about 10 days before, she had a mechanical fall. And in the workup of the headache, a head CT was done that you can see here on the left that shows a left-sided chronic subdural hematoma. So at that point, warfarin was stopped. The patient was observed overnight, and the head CT was done that was stable. And then the patient was basically discharged home with a plan to follow up in clinic in 4 weeks with a new head CT. And at that point, we start warfarin if the 4 weeks head CT looked good. So the patient went home, and 10 days after, she returns to the ED with worsening headaches, difficulties walking, and a pronator drift. A new head CT was done that you can see here on the left. Sorry, on the right of the screen, you can see this expansion of the subdural hematoma with new acute components. So question for the audience is, how would you manage this situation?
Dr. Raper, how would you manage this patient?
Well, I think given the fact that the patient was on anticoagulation and had worsening appearance here, I think the standard first approach would be a Burholz to evacuate the subdural hematoma. We're going to obviously talk about MMA embolization and its role here, which is an important facet of this as well.
Mm-hmm. Yeah.
Can we see the results?
So majority of the audience agrees with Dr. Raper, evacuation with Burholz. And that is actually what was done. So the patient underwent 2 boreholes with very good evacuation. Her symptoms improved, and she was discharged home after 3 days. The plan again was to wait a month, repeat the head CT, and if the head CT looked good, put her back on warfarin. So a month later, the patient returns with a head CT, and you can see that there is a very large chronic subdural hematoma, again, with some small acute components. And she's basically complaining of new onset of headaches for the last few days, but otherwise she is neurologically intact. So question for the audience again is like, how would you manage this patient?
Dr. Raper, what would you do?
You know, when I was in residency training, this patient would either undergo re-evacuation or expansion with a craniotomy. In my practice now, I think that we have a new option which can be very effective for this this problem, which is MMA embolization.
Yeah. Can we see the results?
Yeah. So middle meningeal artery embolization, 75%. And I agree with Dr. Raper. Basically, a few years ago when I was in training, that this would be a patient that you have to take back to the OR to re-evacuate. Basically what we did in this case was an embolization of the middle meningeal artery, or MMA, which this is an outpatient endovascular intervention that it's done with minimal or no sedation. So patients are awake. It's usually transradial access, where we advance very small catheters into the middle meningeal artery. The middle meningeal artery is the artery that irrigates most of the dura and the membranes, which are basically causing the chronic subdurals. So what we do is we advance these microcatheters inside this artery, and then we deliver microparticles that are going to flow downstream and occlude all the microvasculature of the dura and the membranes. And basically, these are some pictures of this particular case. And these are the basically 3 main pictures that we obtained during the case. The first one is doing an internal carotid artery angiogram, because we want to ensure that the ophthalmic artery irrigates the eye. And this is important because 1 in 100 patients, the origin of the ophthalmic artery is actually from the middle meningeal artery. And if that is the case, we cannot complete the intervention. So if we see the ophthalmic artery and this choroidal blush, which is basically irrigating the retina, then we advance our catheter into the middle meningeal, and you can see all this microvasculature going into the membranes, basically completely spanning the cranial vault. And then we deliver the particles, and you can see that the end result is that the main artery is still open, but all the branches were completely occluded by this. So, and the rationale of this is the following, is chronic subdural hematoma formation, like this patient, is due to unbalanced reabsorption over bleeding. It's bleeding more than the capacity to reabsorb of the brain. So the MMA embolization basically prevents further bleeding, and at that point, the reabsorption continues to happen, leading to resolution of the chronic subdural. There are 3 main indications for this intervention. Number 1, you can do upfront embolizations in patients that have previously untreated chronic subdurals. And the patient that we presented, this lady that was on warfarin that has a chronic subdural, just with headaches, would have been a very good candidate for upfront MMA embolization and basically be kept on warfarin immediately after the intervention. The other option of the other indication is prophylactic embolization after you evacuate the subdural. So basically, you have a patient that has a subdural hematoma that is evacuated, and you are concerned that is at high risk for recurrence. So you do MMA embolization shortly after the evacuation. And the third indication is when you have a chronic subdural hematoma that is evacuated, and then there is a recurrence. And at that point, you treat the recurrence exclusively with MMA embolization.
Dr. Savastano and Dr. Raper, we have another question. Dr. Maloney asks, in patients who are vasculopaths or have known carotid stenosis, could we comment on whether or not there's an increased risk of stroke or adverse outcomes for MMA embolization? What do you all think?
Yes, absolutely. I think in general, severe vasculopath, they have increased risk of any endovascular intervention. Having said that, this intervention uses very small catheters. So usually is done with a transradial approach. So there are no complications basically navigating the femoral artery and the aortic arch. You can see that in this particular case, the angiogram includes all the branches of the external. So in reality, we're injecting contrast from the common carotid. And then, so there is no risk of crossing basically stenosis in the internal carotid. And then the catheter that we use to embolize the particles is about 0.5 millimeter in size. So it's really small and can be navigated relatively safely. The risks of having a stroke or blindness or any problem with the access with the MMA embolization is less than 2%, even including vasculopath patients, because most of the patients that are going to have this intervention, they are on blood thinners or aspirin or Plavix or some antiplatelet agents. So the vast majority of patients undergoing this intervention, they are vasculopath, and the risk is still very low, lower than 2%.
Yeah, I definitely agree with that. It's a very safe procedure. The intervention part is extracranial. So, the risk to the CNS is very low. But I will say that there has been one occasion on a very old patient that I was trying to do an MMA embolization for. I was technically not able to get into the MMA due to severe tortuosity of the vessel and atherosclerosis. So the main risk with that, I think, is technical risk of not actually being able to accomplish the procedure.
Dr. Raper, let me ask you a follow-up question. You have a patient with pretty severe ICA stenosis. You're not going to cross the lesion, but you're going to get into the common on that side and then go into the external. You've already given a radial cocktail that includes 3,000 of intraarterial heparin. Do you change your anticoagulation and you give additional heparin in this particular case when you're working around that bifurcation?
It's a good question. It's reasonable to do so. I think, I don't think it's necessary to do a weight-based administration of heparin for these kind of procedures, but I think, given an additional 2,000 units of heparin, it's very low risk. In that kind of case is certainly very reasonable.
Dr. Savastano, would you agree?
Yeah, I think I agree. In my particular case, I would not give extra heparin just for the stenosis. Yeah, I think the risk is really low.
Yeah.
All right.
Yeah, that's a great question though. So there is a lot of accumulating literature about this intervention just in the last 3-4 years. And recently there was this meta-analysis published looking over 1,400 patients. And you can see that the MMA embolization, most of the time was done for recurrent chronic subdurals. So patients that had a subdural evacuation and then they had a recurrence and then they undergo MMA embo. Was as well done prophylactically in about a quarter and upfront in about basically 28% of patients. Upfront means that when you have a patient with a chronic subdural, you treat them only with MMA embolization. So you can see that the 3 indications are actually relatively common. In this meta-analysis, you can see that patients were around 72 years old. About 17% had bilateral subdurals, and many had actually symptoms of brain compression, like motor weakness, gait instability, difficulty stalking, and seizures. Typical comorbidities, not related to the question that was asked a few minutes ago: hypertensive, diabetic, with congestive heart failure, malignancies, oncoagulopathy. And about half of the patients, they were using antiplatelets or anticoagulation. As you can imagine, these patients with chronic subdural hematoma, most of them, they're old, they're sick, and on antiplatelets or anticoagulation. So I think this is what is really important about the meta-analysis that show that the risk of having a recurrence subdural hematoma with conventional management, which is basically boreholes or craniotomy, is about 21%. And we all know this. If you do MMA embolization, the risk drops to less than 5%. So we're cutting the risk significantly. The other thing that is important is that by decreasing the risk of a recurrence and keeping the hospitalization time shorter, as well, the complications are dropping from about 5% to less than 2%. And I think this is important is the surgical rescue. And by that, I mean that when you have a patient with a chronic subdural that you decide to treat with MMA versus boreholes, the risk of taking this patient back to the OR to a re-evacuation with conventional management is over 16%. And if you just do the MMA embolization, there is still a risk to take the patient to the OR in the future, but it's less than 5%. So that is to show that the different indications for MMA embolization are basically strong. So we still don't have level 1 evidence for this intervention. And by that, I mean to have evidence from randomized controlled trials. But if you look at clinicaltrials.gov, there are currently 19 clinical trials that are ongoing and recruiting patients, both supported by NIH and from industry. So very soon, this is likely going to become basically a level 1 evidence intervention. Despite that, you can see the national trends for MMA embolization are basically skyrocketing. You can see that this intervention was described in the 2014, 2015, and very quickly, the number of MMA embolization is rapidly increasing. In this particular case, this is basically the rate of MMA embolization to treat patients admitted with chronic subdurals. You can see that in 2018, 2019, 3.5% of all chronic subdural hematomas underwent MMA embolization. And based on the projection, it is believed that this year we're about 15% of patients with chronic subdural managed with MMA embolization. So this is just my last slide, and this is just basically an overview of the use of MMA embolization in our practice and in the rest of the country where this intervention is done, which is the following. If you have a patient that has a chronic subdural hematoma, and again, I insist, this is for chronic, it's not for acute subdurals. If you have a chronic subdural hematoma, you have to ask if the patient is symptomatic. If the patient is symptomatic, you need to ask if the patient needs or not rapid decompression. By that, I mean, if the patient just have minor headaches or non-localizing symptoms, you can treat this with MMA embolization. So the case that we presented early on was a very good candidate for MMA embolization as a prophylactic therapy. If the patient needs decompression, by that I mean that there is enough mass effect over the brain that the patient has motor weakness or seizures or gait difficulties, at that point, you do have to evacuate the subdural. And then after doing that, you need to ask, is this patient at high risk for a recurrent subdural? And by that, I mean, is the patient on antiplatelets or anticoagulants or has liver failure or thrombocytopenia? So any of the high risk features for a recurrent subdural, those are very strong argument to do an MMA embolization. And the MMA embolization doesn't need to be done in the same hospital or in the same day. It can be done even a few days later as an outpatient intervention. So going up to the diagram, if the patient is not symptomatic, then you need to see how big is the subdural. If the subdural is large, like a centimeter or more, especially if there is midline shift, you can treat this with MMA embolization. If the subdural is relatively small, but the patient is at high risk for expansion, for example, patients that have cirrhosis or that they need to be on antiplatelets or anticoagulants, then you can do the MMA embolization. And there is good data showing that if you do that, the risk of expansion, it's actually really low. It's lower than 5%. So that would be kind of our working. So happy to take any questions.
We have another question. from the audience. This is from Dr. Jake Young. So how quickly do chronic subdural hematomas reabsorb after MMA embo? And are there any early or immediate changes in the hematoma volume?
Yeah, that is a great question, and there is a lot of research ongoing about that. Usually, if you do the embolization, you're expecting that in a head CT done 2 to 4 weeks, the hematoma is about a third smaller. And usually at 2 to 3 months, the hematoma has completely resolved. Of course, it depends on how large is the hematoma when you start. But most of the times after 2 or 3 months, there is a complete resolution, at least in our experience. What is your experience, Dr. Raper and Dr. Abla?
Yeah, that's what we see. I typically will just get a CT scan a month later if the patient's stable. But typically the symptoms improve before the radiographic improvement.
Yeah,
I agree with that.
Yeah, and so to summarize, Dr. Savastano, it seems like we have three very good indications for doing this in terms of temporal sequence. We can do it early, before surgery, middle time point, concurrent to surgery or immediately after surgery for somebody with mass effect, and then late, after a recurrence after surgery. So I just want to remind the audience that we do have 3 good indications and 3 time points, and worth considering in all of those, as you've nicely outlined in your diagram.
Yeah, absolutely. And this is a relatively new intervention that is becoming more and more common. So we will be always happy to basically discuss any cases to see if the patient could be a basically good candidate. Just send an email to this email here.
Any other questions? All right. Thanks, Dr. Savastano. I'm going to show a quick case as well. All right, so we have a 50-year-old patient. This actually happened many years ago, admitted in 2006. History of hyperlipidemia, 5-minute episode of a TIA, right-sided weakness, resolved spontaneously, found to have stenosis of an intracranial artery. Patient's already on dual antiplatelet therapy. So I'm going to ask our panelist, Dr. Raper, what do you think about this case and this patient's angiogram?
Yeah, so as you can see, this patient has a very high-grade stenosis in the MCA, which has been symptomatic. The initial treatment with a single ischemic episode would be dual antiplatelet medication.
Yeah. And Dr. Savastano, what are your thoughts?
Yes, so I think that first of all, we have to do a very good workup of the etiology of this stenosis. It's probably based on the age and the angiographic appearance. It's likely to be intracranial atherosclerosis, but there are other conditions that can look alike that should be worked up. Assuming that the leading diagnosis is intracranial atherosclerosis, I totally agree with Dr. Raper. The first line management is what we call maximal medical management, which usually is a dual antiplatelet therapy with high dose statins, exercise, weight loss, control of diabetes, and stop smoking.
Okay. Now, let's say he's failed those. What would you all do? He's been on dual antiplatelets, having symptoms, and he's not able to medically optimize. He continues to have TIAs. So
yeah. So when you are on maximal medical management and you fail and you have basically progressive symptoms, it's a very malignant disease. The natural history of these conditions is extremely poor, and usually this evolves to a probably complete occlusion of the vessel and a massive stroke on the dominant hemisphere, assuming that is the left side. So at that point, I would definitely escalate on the intervention. And there are, I think, 2 approaches that could be considered. One is the endovascular route, which probably is going to be a submaximal angioplasty. By that I mean opening a balloon inside the stenosis, trying to create more lumen. Or the other option is to consider a bypass, basically providing more flow into one of the cortical branches of the MCA.
Yeah.
Yeah,
Dr.
I,
Raper?
I agree with that. Absolutely. That's the way to think about it. And the thing that you need to look at for this kind of atherosclerotic problem is whether the vessel is stenosed or whether the vessel is already occluded, which will affect the safety of bypass as an option and the feasibility of endovascular treatment. So for me, if this appearance was a recurrent case, my first approach would probably be balloon angioplasty, submaximal balloon angioplasty, and see how the patient does after that.
Yeah. Excellent point, guys. Excellent points. So he did undergo angioplasty back in 2006. You can see a very nice result was obtained, and it's been durable. This is 2019, 13 years later. So one submaximal angioplasty resulted in a good, durable outcome. But here's his right side back in 2006 and asymptomatic. Now the patient comes back in 2019 and he's having TIAs and worsening symptoms on the other side. So left hemibody symptoms, mostly in the left arm, and mostly with exertion. And so we're going to get more imaging. And here we can see MRI perfusion. We can see the cerebral blood flow is decreased in the right MCA territory. He undergoes a repeat angiogram, and this is what it shows. Again, he's still on aspirin and Plavix, and this is what we have. So what do you all think? Dr. Raper, why don't you go first on this one? What would you do?
Sure. I mean, we have a very high-risk lesion here. It's progressive. And I think Dr. Savastano highlighted this before. The natural history for this is very bad. This patient is at high risk of developing, a symptomatic stroke on that side. And we have a high-grade stenosis over a fairly long segment. Endovascular treatment is an option here. But I think that bypass surgery is also a very reasonable option.
Yeah, Dr. Savastano, your thoughts?
Yes. So, in full disclosure, it's the first time that I'm looking at this case, and I think it's very interesting. Early on, I thought that this was intracranial atherosclerosis, but now I'm wondering more about this. There are phenotypes in the angiogram that you can see that the supraclinoid ICA is progressively getting stenosed. And Dr. Abla, can you point in the screen, basically the ophthalmic artery and the...
We can see the ophthalmic here. This is the takeoff of the PCOM. So the stenosis starts in the supraclinoid segment.
Yeah, and I'm bringing this up because that is one of the hallmarks for Moyamoya disease or Moyamoya syndromes as well. So I wonder if that is the case in this patient that back in 2006, we just saw a very early presentation of the disease. So if that is the case, Moyamoya disease or syndromes, usually they have negative remodeling of the artery, meaning that the artery is getting smaller and smaller over time, and they tend to respond less to angioplasty. The other thing important about this case that it looks like the symptoms are hemodynamical in origin, meaning that he had these recurrent neurological deficits, probably when the blood pressure drops, when he's exercising or something, and then when he had basically increase in the cerebrovascular perfusion, he has basically improvement in the symptoms. So meaning that rather than treating this stenosis, probably the patient would benefit from increased flow to the hemisphere. So I would probably basically favor a bypass in this particular case.
Yeah, and those are excellent points, and that's actually what we did, because this was a long segment, maybe difficult to angioplasty, and the problem here, he's already on aspirin and Plavix. Here you can see the lateral view, you can see the ophthalmic, you can see it starts in the supraclinoid segment, goes into the M1. You don't see an A1 on this side. And so again, this is a problem with flow, not thromboembolic. So angioplasty was deferred. And the patient actually was observed for several months with continuing TIAs. He wanted to observe it first, but then ultimately elected a revascularization procedure and underwent a bypass. And here's this particular case. We can see the M4 recipient, and then we can see the STA donor. These are straightforward cases with very little surprises. They're formulaic. We do them the same every time we find an M4 recipient. We use the STA. The disease process can be challenging, but the cases, typically, unlike an aneurysm case, go the same every time. We find the STA, we find the M4, and then it's an anastomosis with interrupted suture. And you can see the results. And here's the bypass on the right side. The MCA was already pretty narrow, and not uncommon to see it completely go down after the bypass with the reversal of flow in that MCA territory. This was not symptomatic in this patient because he had this for some time and had already developed some collateral here. But because of the increase in flow that we provided, that was in excess of the anterograde or the native flow, the patient had no further TIAs and now is 3 years out and remains on aspirin and Plavix. So, so any other comments on that case? I was just going to show a few background.
Just a couple of comments. I think this patient was managed very well. That was a great result. I think that if you consider that the patient has Moyamoya disease, the problem here is lack of flow to the brain. So there is no medication such as aspirin or Plavix that's going to increase that. That is basically to control thromboembolisms.
Yeah.
And the treatment of Moyamoya disease, it's significantly, so the outcome and the complications are ideal early on in the disease. So basically doing bypass surgery early on in the disease has a very low risk, lower than 5%, and the outcomes are much better in the long term. So my only comment is that many times the sooner you can consider revascularization on these patients, the better for them.
Yeah, that's a great point, Dr. Savastano. I would agree with that as well. Dr. Raper?
I think the difficulty is sometimes it's not that easy to know which bucket the patient falls into. Like, for example, with this case, the patient presented in 2006, was treated with an angioplasty, which actually did a very nice job and durable job for treating that left-sided problem, but then went on to develop a right-sided problem. So that's where we really try and dig into the findings of the hemodynamic workup. So, we use perfusion imaging. Sometimes we try and challenge those patients with acetazolamide challenge to see exactly what is the risk, how maximally is the brain trying to utilize the oxygen that's available to it, and how necessary or how effective is a bypass going to be to augment that for the patient.
Yeah, definitely. And you all raised great points. It's not always easy to tell the difference. And so we know that Moyamoya and atherosclerotic disease are major causes of stroke and disability. Moyamoya often affects a younger patient population who haven't had time for atherosclerotic development. Bypass, like Dr. Savastano and Dr. Raper mentioned, is a mainstay in treating and preventing stroke and hemorrhage, according to the Japanese literature, preventing hemorrhagic Moyamoya from recurring. Medical management is first line for ICAD. We have two landmark trials, Sampras and more recently Weave. Sampras is from 2011. It basically showed that medical management was superior to stenting for intracranial atherosclerosis. But then Weave also showed that when properly selected and done at high volume centers, angioplasty and stenting can be done with a lower procedural morbidity rate when well selected. And what we can see here in this graph on the right is we can see that the periprocedural event rate in Sampras was 14.7, which was higher than the rate of stroke or death with just dual antiplatelet therapy. But when patients have 100% qualifying event stroke and are refractory to medical therapy, then we've really run out of options. And those patients, when treated with angioplasty and stenting, as we see in the Weave trial here at the bottom, had a much lower periprocedural event rate and even more favorable than the medical arm at 30 days in terms of stroke or death. So when we think about revascularization in neurosurgery, as our panelists mentioned, for Moyamoya, bypass is first line. We don't have good angioplasty or stenting options for Moyamoya. It's a very different disease. The angiograms look very different, long segment stenoses or occlusions. With atherosclerosis, we start with dual antiplatelet therapy, move on to angioplasty or stenting if possible, and then bypass for patients where flow is really an issue and we are unsuccessful with angioplasty. When we think about flow replacement, we won't touch on this, but we do bypass to replace flow when we reroute flow around an aneurysm or a tumor as well. And these are the treatment options. We have intracranial atherosclerosis, angioplasty and submaximal angioplasty, and then we have stenting. Here's a lesion. This is a wingspan stent. This stent is going to prevent further restenosis of this vessel. When we think about surgical options, we have two types of bypasses, direct bypasses and indirect. These indirect procedures we perform only when there's no good recipient, and we showed that in kids at least, these are equivalent, if not better, for revascularization indirect, whereas in adults, the direct is the first line. This is basically just the nuts and bolts of how to do the procedure, which you all have already seen and we've already shown. And then in terms of our how do we manage these patients in terms of when they present with an acute presentation of a chronic illness. So we know somebody who comes in with M1 stenosis with new TRAs or CVA should go on DAPT. And then we observe those patients because we want to make sure that they're not failing medical therapy. So they have to be observed in the hospital on medical therapy. And if they don't have any more events on medical therapy, they can undergo Sampras protocol. But if they do have more events, then treatment needs to be escalated. And that's basically what this slide is showing, that we escalate treatment for patients who fail DAPT in the acute setting with either angioplasty or angioplasty and stenting. And for those when it's not possible, then we move to bypass. And we'll stop there and we'll take any questions.
That was great, Adib. I would just add one thing. A common story in the endovascular side of things, as you know, is that technology changes very quickly. And we had the previous generation of intracranial stent technology had some issues with it that were technical in nature, but there are certainly new stents being developed and new technologies that are being used now that making this procedure safer, and so that's something that we're actively involved in among our group, is looking at some of that.
Yeah, definitely. Any more questions from the audience? Any further comments from our panelists?
No, I think we should do these more often, actually. It was fun.
Yeah, absolutely. All right, well, thanks for your attendance. Thank you, Dr. Raper, Dr. Savastano, for your excellent presentations. Enjoyed this. And yeah, thanks